Welcome to the UC Quits webinar, Medications for Smoking Cessation, presented by Dr. Lisa Kroon. My name is Jennifer Mataquari with the Smoking Cessation Leadership Center at UCSF, and I will be your moderator for today's webinar. This webinar is one in a series of 5 webinars designed to educate providers on tobacco cessation and health systems change. The UC Quits project aims to further reduce tobacco use and exposure, the leading cause of preventable death, by developing a UC tobacco cessation network and UC e-referral system with the California Smokers Helpline. Headed by Dr. Eliza Tong from UC Davis, this ambitious project involves all 5 of the University of California health science campuses to ensure that every smoker receives support at every encounter. This system-wide collaboration is a historic change in how healthcare providers can ensure that smokers can get help to quit smoking by using the electronic healthcare record. Learn more about UC Quits at www.ucquits.com and the California Smokers Helpline at www.nobuts.org. Now I will introduce today's speaker. Dr. Lisa Kroon is a professor and chair of the Department of Clinical Pharmacy in the School of Pharmacy at the University of California in San Francisco. She has been a member of the UCSF faculty since 1996. She practices in the UCSF Medical Center's Adult Diabetes Clinic and Diabetes Teaching Center, where she cares for people with diabetes and chronic illnesses. She co-directs the UCSF Fontana Tobacco Treatment Center, where she has been a smoking cessation provider for over 10 years. And now for Dr. Lisa Kroon.
Thank you, Jennifer. It's a pleasure to participate in the UC Quits webinars. And as mentioned, my focus today will be talking about medications for smoking cessation. But I want to point out that this is not in place of non-pharmacologic methods for quitting. So when we look at non-pharmacologic, that would be counseling. So it's still important as providers, if you're considering medications to assist your patients to quit, that we still enroll them in behavioral support and counseling. And other speakers will be talking in the webinars about the California Smokers Helpline, but your institution or local resources may have group cessation counseling, or maybe you even provide one-on-one counseling with your patient. Because we know that combining medications plus counseling are more effective than either alone. Now, everything I'm going to be presenting today is heavily based in evidence and comes from the tobacco treatment guidelines that were last published in 2008, titled Treating Tobacco Use and Dependence. And this is a direct quote from this clinical practice guideline, stating that clinicians should encourage all patients attempting to quit to use effective medications for tobacco dependence treatment, except where contraindicated, which I will highlight, or for specific populations for which there is insufficient evidence. And I'm going to go over what these specific special populations are. Now, that said, in 2011, in a CDC publication, we know that about 48% of people are advised to quit by their healthcare provider. But unfortunately, very few actually use medications. And in this publication in 2011, of those surveyed who were current smokers, only about 30% used medications during their last quit attempt. So we know there's great room for improvement in terms of offering these very effective medications to treat nicotine dependence. Now, what are these special populations? So currently, pharmacotherapy or using the smoking cessation medications is not recommended for pregnant smokers. So that should be no surprise for all pregnant women. We try to avoid medications as much as possible. And there's really a lack of evidence showing pharmacotherapy being all that effective. This patient population tends to be very motivated to quit during pregnancy. And in fact, it's the postpartum period where women can be very vulnerable to start smoking again. That said, if a woman is unable to quit smoking during pregnancy without medications, we indeed will consider some. We generally look at the nicotine replacement therapy first. Smokeless tobacco users, so there's actually no FDA indication for any of the medications. That said, certainly a person who chews or uses smokeless tobacco can be addicted to nicotine, so we can consider medications. Now, this next special population are what we call light smokers, so people smoking fewer than 10 cigarettes a day. So in general, the clinical practice guideline would advise us to not use medications. I'm going to go in a little bit more in detail because I feel this is a bit of a gray zone. So when I have patients who are maybe described they might smoke 7, 8 cigarettes a day, I really probe and ask, well, when you can't smoke, are you experiencing nicotine withdrawal symptoms? And if the answer is yes, I absolutely will consider medications for them. And then the last special population are adolescents. So just to be aware that when I cover the nicotine replacement therapy for the non-prescription or the over-the-counter ones, these are restricted to adults. So if you're going to use nicotine replacement therapy in a minor, that would require a prescription. But also in this population, they tend to be more light smokers, and in fact, strategies to help adolescents quit smoking can be what are more effective often are behavioral. So let's talk about the different medications. And what I'm going to be covering is specific for the FDA-approved medications for cessation. And these are the medications that are included in the clinical practice guideline. So I'll be going over the nicotine replacement therapy, for where we have the gum, the lozenge, and patch, which are also available over the counter. The nasal spray and inhaler, which are prescription only, and I find many providers a bit or less familiar with these NRT formulations. And then I'll cover bupropion sustained release, and which the brand name for that is Zyman, but it's available generic. And then we have varenicline or Chantix, which is still currently available by prescription only and by the brand product only. So I'll first talk about the nicotine replacement therapy products, and I will refer you to a pharmacologic product guide, which is a one-page sheet that's available on the UC Quits website that is a nice summary of everything that I'm going to be covering in the next few minutes here. So I've found that it's a nice little cheat sheet to actually have with me when I'm in clinic and I'm looking to provide the medications and order the medications for patients. So we'll start with the nicotine gum and lozenge. So I have pictures of the brand products here, but they are available generic. What these are, in terms of looking at the gum, is a resin formulation, and these are buffered to enhance buccal absorption of nicotine. So you may be aware that nicotine's absorption is pH dependent. So we have buffering agents to raise the pH of the nicotine to enhance absorption. Both the gum and the lozenge are available in a 2 and a 4 milligram dose, and they have a variety of flavors available. So for the gum, you may have patients say that they tried the gum, but it tasted terrible, and this very likely was the original flavor, which was very peppery. So if a person actually liked the gum, you may still discuss that with them and just share with them that there are different flavors available now. So that's a nice option for people. So what is the dosing, the recommended or labeled dosing for the gum and the lozenge? Well, the manufacturer here uses this term called time to first cigarette. And this is an indicator of level of nicotine dependence. So how soon does a person have their first cigarette upon waking? And if a person has that first cigarette within 30 minutes, they would recommend using a 4 milligram dose for the treatment, for the duration of treatment. And then if a person waits longer before smoking when they wake up, so a cutoff here of 30 minutes, we would say to use a 2 milligram dose. Now, at any time, with all the nicotine replacement therapy, We want to make sure to follow up with people to make sure that their withdrawal symptoms are being appropriately alleviated. And we can always change the dose either way depending on a person's response. So that's the general initial dose. And then in terms of the dosing schedule, this is shown here. And so with the nicotine gum and lozenge, the dose would be to use one piece every 1 to 2 hours while awake. So you're really looking at least 9 to 10 pieces a day of a particular gum or lozenge. And then that's for the first month and a half. And then you can see for weeks 7 through 9, we extend the dosing interval, and then further at weeks 10 to 12. But this is just a guideline. So I often have people at a month and a half say, yeah, well, the box would say I shouldn't use it as often, but I feel like I need to. Absolutely fine. It's whatever it takes to help relieve withdrawal symptoms. Now I'd like to go into how to actually use the gum. And I actually just had a patient last week in our group class who just chewed the gum like a regular piece of gum. And sure enough, he was having a lot of stomach upset. So you do not chew the gum like a regular piece of gum. So as I mentioned, this is a resin. And so what you first do is you start to chew it. And when you get a sign of a peppery taste or a slight tingling sensation in the mouth, that is a sign that the nicotine is being released. And at that point, you park the gum between your cheek and gum, park the piece of gum between the cheek and gum. And we're looking for buccal mucosal absorption of nicotine. Then when that taste or tingling fades, you chew it again. So it's this repeat of chew, park is how you're going to actually chew this piece of gum. And a piece of gum generally will last about 30 minutes. So if I give you a visual here, so you'll start to chew the piece slowly, stop it at the first sign of a peppery taste or the flavor of the gum, and then you park it, leave it there for a little bit, and then chew it when that sensation goes away, and you keep doing that for about 30 minutes. So you can see this is very different than chewing a regular piece of gum. Now, what about the lozenge? So the lozenge is, frankly, a little bit easier to use. You don't have to worry about this park, chew, park, chew. So as a lozenge, it's just designed to dissolve slowly and completely. So a person would just place this in their mouth and rotate it around different areas of the mouth, and generally even the mini lozenge and the regular size lozenge, they both dissolve in about 20 to 30 minutes. And it is important to let a patient know they shouldn't chew it or swallow the lozenge. They're going to get a lot of gastric upset. In fact, any nicotine that is swallowed and gets into our GI tract, while a good portion gets absorbed, we have very high first-pass metabolism of nicotine, so none reaches the system, and that's why we don't have an oral dosage form for nicotine. Other important counseling points with the gum and the lozenge. So as I mentioned, for the first 6 weeks of treatment, a person is really looking at using at least 9 pieces a day, a piece every 1 to 2 hours. So you can imagine that that can be challenging for people to adhere to. And in fact, many people really underdose the gum and the lozenge and don't use enough of it. And that may be a reason for when they tell you that it didn't work for them. So really probe for that. The gum and the lozenge, and actually none of the nicotine replacement therapy products, will provide that same rapid satisfaction that smoking does. So it's important for people to understand. Now, because of that whole pH-dependent absorption, when using the nicotine gum lozenge and also the inhaler that I'll get to later, it's important to not eat or drink 15 minutes before or while using the product. And especially acidic beverages like coffee, juice, or soft drinks, because that will lower the amount that gets absorbed. Some will still get absorbed, but just won't be quite as effective. And we want to make sure we're really helping people get the most out of their medication. So to summarize, the gum and the lozenge, some people like both the gum and the lozenge because it might satisfy oral cravings. But we have other options for that too. Some people use toothpicks or cinnamon sticks. These have been shown to delay weight gain, but not necessarily prevent it. So I actually don't. It's not usually a reason to choose it. Why? Well, probably because they have, they're keeping their mouth busy, and you can't eat or drink for 15 minutes before or while using that. A key benefit of the gum and the lozenge is that you can titrate. So while the general dose is a piece every 1 to 2 hours, if a person needs another piece, and because they're having, feeling a trigger to start to smoke, go ahead and take another piece. Lots of flavors now. And in terms of the gum versus the lozenge, a niche for the lozenge is that it's easy to conceal. So depending on a person's environment, perhaps chewing gum may not be socially acceptable, so the lozenge might be an option there. I already talked about challenges with adherence. And so when I get to, I'm going to talk about combination therapy, but these quick-acting nicotine replacement products are very nice to combine with the patch, but I'll talk more about that a little bit later. The gum may be a challenge for people with significant dental work, so you can talk to them about that. Important to actually, go through how to chew the gum. And then all of the oral nicotine replacement products can cause some GI upset, hiccups, little digestion, heartburn, indigestion, but again, with proper use, we can minimize that. So now I'm going to go on to really what's probably still the most commonly used, not only nicotine replacement product, but smoking cessation medication, and that's the nicotine patch. So we know that nicotine is well absorbed across the skin, and the difference, however, as I mentioned, that we have none of the NRT provide that same rapid satisfaction as inhaling a cigarette, where the nicotine reaches one's brain in 11 seconds. This is just a much lower level, and it provides a very consistent level of nicotine. Now, here is the dosing for the nicotine patches. There's one brand available now, the Nicoderm CQ, and there are several generics. And what I advised here for patients is go where they can find the cheapest price for their nicotine replacement therapy. And we have recommendations on that. But the store brand often is actually the actual brand making the medication still. So in terms of the dosing, the cutoff here that the manufacturer uses is half a pack a day. So to know that there are 20 cigarettes in a pack, I find providers may not know that. So if you're smoking a half a pack or less a day, you would start with a 14 milligram for 6 weeks, and then you can see the step down there. And then for a, quote, heavy smoker, which would be more than half a pack, you would start with a 21 milligram. So recall when I talked about special populations, which is a light smoker, which was less than 10 cigarettes a day, where the clinical practice guidelines says perhaps do not use medications. This product has specific labeling for the light smoker. Again, so this is where I'll probe a patient and really make an assessment of whether we feel that they would need pharmacologic therapy. But you can imagine for a person who smokes 1 pack a day versus 2, or maybe you have someone smoking 3 packs a day, the dose on this label here is still 21 milligrams. And for that heavier smoking, that actually may not be enough. So there is high-dose nicotine patch use. And so for a 1 to 2 pack a day smoker, you may even consider 28 milligrams or even 35 milligrams a day. So here we might be using multiple patches. And then for a 2 pack a day or more smoker, we've even used 2 21 milligram patches a day or 42 milligrams. So again, this is the importance of follow-up with your patients to making sure that their withdrawal symptoms are being adequately relieved. The pharmacologic product guide goes into specifics on how to apply the patch. Actually, the boxes have very good labeling, so I'm not going to cover that here for purposes of time. But what's nice with the patch is it provides a very consistent low level of nicotine, easy to use, 1 patch a day, and so adherence issues are a little bit less. Now, of course, the disadvantage is if you can't titrate quickly with the patch, as you all would know. And so this is where the combination therapy comes into play, and I'll talk about that. Allergic reactions to the adhesive it can be an issue. So the adhesive on that patch is intended to have that patch stay on the body for 24 hours. So some reaction is expected, but many people, it's just a couple of days of a little bit of irritation and it goes away, but you might want to follow up with them. So certainly any patient with a severe dermatologic condition like eczema, this may not be an option for them. I will add in terms of using this for 24 hours that one of the challenges with wearing it for 24 hours is now a person has a low level of nicotine while they're sleeping, and this can cause some insomnia or changes in dreams, even to nightmares. And so if that happens with a person, the solution is very easy. They just take the patch off then before they go to bed. The last two nicotine replacement products are the nicotine inhaler and the nasal spray. And I'm going to talk more about the inhaler, the nasal spray, because we are seeing more and more use of this. So what this is a nicotine inhalation system. And what you see here on the right of the picture is a plastic mouthpiece. And then at the bottom left is the cartridge. And that cartridge is just a porous plug that contains 10 milligrams of nicotine and a little bit of menthol. And that is it. So it's pure, clean nicotine in that cartridge. And what's nice about the cartridge or the inhaler is some people are challenged with that hand-to-mouth ritual of smoking, and this kind of mimics that. Now, in terms of dosing of this would be using one cartridge every 1 to 2 hours. So again, this is a short-acting, quick-acting nicotine replacement therapy. One cartridge will provide 80 puffs of nicotine or about 20 minutes of continuous puffing. So a person kind of puffs on it for a little bit. Again, they're not inhaling this like they would a regular cigarette. We're getting primarily nicotine absorbed across the buccal mucosa and the back of the throat. Another summary slide here. So for the inhaler, as with the gum and lozenge, we can easily titrate, and then the mimicking the hand-to-mouth ritual. So some people like that. Other people will tell you, nope, I want to break that, so I don't like the idea of an inhaler. And recall that this is prescription only. So disadvantages, as with all the as with all the quick-acting, short-acting NRT, we need to dose this more frequently. People will describe some initial back of the throat irritation. The cartridges in very cold conditions, generally not a concern, and too much in California may be an issue. And then the label does caution against use with people with underlying bronchospastic disease. So the label says this, but I just want to clarify, this is not like an inhaler that we use with like albuterol for asthma or COPD. There's no propellant. It's just a person is inhaling a vapor of the nicotine. So if smoking is not causing bronchospastic problems acutely, this product neither should. So again, I have not seen that to be an issue with this, but I just wanted to let you know that you will see that on the label. And then the final nicotine product is the nasal spray. And in my years of working with people, I've only had a handful of people want to use this. Most people don't really care to put a spray in their nose for their medications. So you're not going to see this used a whole lot, but just to know it's available. A dose is 1 spray in each nostril every 1 to 2 hours. So again, you can kind of see a theme here with the quick-acting NRT. It's a dose. So either a piece of gum, a lozenge, a cartridge, every 1 to 2 hours. To note, though, of all the rapid-acting NRT, the nasal spray does have the most rapid absorption. Advantages, we can easily titrate. Now, even a person who smokes is not used to necessarily getting a blast of nicotine in their nostril. So people this product does have unique side effects. So you can get a runny nose, tearing of the eyes, nasal and throat irritation, but over time a person generally develops tolerance to this. Other people who we would probably not use this in was someone with a chronic nasal disorder, severe allergic rhinitis, that type of thing, and then it does require frequent dosing. So So now I'm going to move on to the two non-nicotine medications that are FDA approved. First one being bupropion sustained release. So this is a non-nicotine cessation aid, and as you know, this is used for depression, but a person does not need to be depressed for this to be effective to help them quit smoking. And the reason it's thought to help people with alleviating nicotine withdrawal is because of its preventing the reuptake of dopamine, which is unique as an antidepressant. As you know, most antidepressants, we're looking at serotonin, and with bupropion, we're preventing the reuptake of dopamine and also norepinephrine. So that's why this medication is thought to specifically help with smoking cessation. Your pharmacologic product guide has the dosing on there, and I'll just let you look at that. But this medication will never be available over the counter for people. And then I'll start with the disadvantages side of the slide first. So bupropion has a very rare risk of seizure, like less than 1 in 1,000. And so as providers, we need to screen to make sure that this is safe. So you would be needing to screen people for either a current seizure disorder or even a history of seizure disorder. This may not be your go-to choice here. Other conditions that would predispose to seizures, such as anorexia, bulimia, abrupt withdrawal of benzos, or alcoholism, these are other conditions that would be of concern for using bupropion. Now, both bupropion and varenicline carry a black box warning for neuropsychiatric symptoms. And for bupropion, this is not unique to bupropion. All antidepressants carry this. So we do want to monitor and counsel patients for any changes and negative changes in mood after starting the medication. What's the advantages? Well, people will sometimes not be familiar with bupropion as an option, and so it provides another option for people. If a person does have depression, that's something to consider because you can be treating both with this one medication. It's a pill, so it's easy to take. You actually just take it twice a day, so that's easier for adherence. And then bupropion has been shown to help delay weight gain. So the final medication I'll cover is varenicline or Chantix. Now, this medicine was specifically developed for smoking cessation. Now, the medication I was just talking about, bupropion, was not developed for smoking cessation, but in the studies in depression, people were finding they had less of a craving to smoke, and that's really where that came from. But varenicline specifically developed for smoking cessation, and this is what's called a partial nicotinic receptor agonist, and it binds to the alpha-4 beta-2 nicotine acetylcholine receptors in the brain. So it binds to the same receptors that nicotine do. But as a partial agonist, this is now only causing a low-level agonist activity. So it doesn't cause the same degree of stimulation that nicotine does. And as a result, it just helps to reduce the symptoms of nicotine withdrawal. Now, to know that it competitively inhibits the binding of nicotine, which means if the varenicline is on board and binding to these nicotine acetylcholine sites, if someone smokes and thus has nicotine coming in the brain from that, it theoretically would have nowhere to bind. So if someone has a slip on varenicline, they often will describe that they didn't feel anything, and that's because the varenicline, which has a half-life of 24 hours, so therefore should be circulating at steady state, there's nowhere for that nicotine to bind from the cigarette. But that's not a reason to help them stop. It's just sort of an added benefit. So it mainly works to help reduce withdrawal symptoms. In terms of the dosing for varenicline, it's a little bit more complicated, but it actually comes, and what's shown in the picture here is sort of this first little starter pack. And so the initial dose is a 0.5 milligram once a day for 3 days, and then we go up to a 0.5 milligram twice a day. for the next 4 days, so for the first week, and then for weeks 2 and onward, we're looking at 1 milligram twice a day. And the reason it has this dose titration is a very common side effect is insomnia and nausea. And so that dose titration helps with that nausea. But you do want a person take Chantix with food and a full glass of water. So as I mentioned with bupropion, varenicline also has the black box warning for neuropsychiatric symptoms. So that said, this is considered a first-line drug for patients. If you have a patient with a mental health condition like bipolar or schizophrenia, perhaps this is not your first go-to, but it doesn't mean you cannot use it. And we would just follow that patient closely to make sure they're not having any of those symptoms. Advantages of varenicline, again, it's a pill like bupropion, easy to take twice a day. And what I find in the group classes is sometimes people have tried nicotine replacement therapy, maybe they've tried bupropion, and this then provides another option for them to consider. So let's look at effectiveness here. And what this slide shows is just the long-term quit rates for these medications. And this is just the drug, these are not head-to-head studies, but it's active drug versus placebo. And what you want to see here with the yellow bars, which is the active drug, versus the blue bars, which is placebo, is that these medications roughly double to perhaps even triple people's success at quitting. And that's what I describe to patients. We know we have several medications that can help, are well proven to either double or triple your success at quitting. So now let me talk about combination therapy, because this is what we use a lot with our patients at the UCSF Fontana Tobacco Treatment Center. So somewhat analogous to how we treat pain, where we have a long sustained-released opioid with a quick-acting one, or even how we treat asthma with a long-acting steroid plus a quick-acting albuterol. Same concept. So here we look at using a patch, providing a low-level, constant level of nicotine, plus a quick-acting or short-acting formulation as needed. And a lot of people have never heard of this. A lot of providers have not heard of this. And I'll tell you that this is a very attractive option for your patients. To know that bupropion sustained-released is also FDA approved with the patch, but I would also add on to that short-acting gum lozenge, for example, as needed for cravings. Currently, varenicline is not approved for combination therapy. So many of you are probably thinking about, well, what about e-cigarettes? And I don't have a lot of time to go into this, but e-cigarettes or electronic cigarettes, the general term for these products are electronic nicotine delivery systems. And these are my current recommendations for clinicians to consider. E-cigarettes should really be discouraged for non-smokers among adolescents and adults. So if a person doesn't smoke a cigarette, we really want to be discouraging the use of e-cigarettes because we know this can lead to nicotine addiction. And in adolescents has been shown to be a gateway to smoking. And in my opinion, until more is known about the potential risks, we really these should not be promoted as a safe alternative to smoking. And we just don't have enough evidence right now. So until long-term safety and efficacy data are available, I still recommend the FDA medications that I've discussed here. Now that said, if I have a person who's ready to quit smoking and they tell me, really I'm not interested in any of those FDA-approved medicines, I want to try an e-cigarette, I will go over that with them. But if they believe that that's going to help them quit, then I say let's go for it. The concern with the e-cigarettes, we really, as you know, they're not regulated. The ingredients in the liquids may irritate the airways. There is concern for the secondhand vapor exposure, and they are finding cancer-causing agents in these. So we just don't know a whole lot about them. So I always get asked about it, but that's my general approach. So what about the cost of these medications? So fortunately in California, the coverage is getting better and better. And in fact, Medi-Cal did add the nicotine gum and lozenge last summer as part of the coverage to the patch, and so you can use combination therapy. But this slide shows you the actual cost. So the blue bar being the brand, yellow the generic, and this is the average cost per day. And this is actually a national slide we use, which shows the average cost of the pack of cigarettes being about $6. But I don't know, in San Francisco here, it's $8 or more. So you can see that the cost of these medicines per day is either close to or substantially less than the cost of cigarettes. But the problem is when a person goes to buy, let's say, a box of patches, they have to put out $40 or $50 for that, and that can be cost prohibitive for people. But as providers, I would just encourage you to always prescribe these medicines, get a prescription even for the over-the-counter ones. And unfortunately, if you have to do a prior authorization, there are still some barriers put up there for patients. But what I'm finding is the coverage is better and better. So to summarize, to maximize success, we want to make sure that we're offering counseling and medications to our patients in combination, counseling plus medications. And we really want to encourage people to use the medications because we know they work. I really view this as, we're treating a chronic condition called nicotine addiction, just like we would treat diabetes or hypertension, and we have medications that we know work for them. So not to view the medications as a crutch, or some people feel, well, I shouldn't need medications. I should be able to do this alone. And we know actually people who try and quit cold turkey have a success of less than 5%. So let's use the medications because we know they work. And the first-line medications will reliably increase the rates by about 2 to 3-fold. And then finally, just to consider combining the medications as an option for your patients. So that concludes my very quick and brief tutorial on medications for smoking cessation. Thank you.
Thank you, Dr. Kroon, for your informative presentation on medications for smoking cessation. Free CME and CEUs of up to 0.25 credits will be available for those who complete this online activity. The webinar link and instructions to claim credit will be posted on the UC Quits and CME California websites. For questions on the UC Quits project, please contact Dr. Elisa Tom. Thank you for your time.